So I picked this topic because I think there are kind of changes in the management, and so it would be a good way to review some of the surgical as well as medical options. So I'm going to start off with a case. It's an 11-year-old Chinese girl with 2 weeks history of nausea and vomiting. Apparently at the time, no headaches, no fever and chills or kind of upper respiratory tract symptoms. And she noticed that the vision in the left eye is blurred with central blurring. Otherwise, everything is pretty good. And the vision in the left eye is 2400, and pretty reasonable refractions. And there is a decreased color visions in the left eye on the Shihara chart, and also there's a left relative afferent pupillary defect. So this is the right eye, which is essentially normal. The left eye, you can see there's a vascular tumor at the optic nerve with exudations extended towards the macula. In fact, you can see there's shallow subretinal fluid surrounding the tumor, almost 360. Here's a composite fundus photograph of the left eye showing the larger extent of the fluid that actually you can see the exudate almost like watermark that extended almost a couple of this diameter from the vascular tumor. The fluorescein angiogram showed hyperfluorescence with this vascular tumor with kind of a little bit lobular appearances, and minimal amount of kind of collections of exudate at the macula, but not really CME there. And the differential diagnosis include a whole list of things, but the retinal capillary hemangioma or hemangioblastoma probably topped the list of the considerations. So the investigations was carried on. The ultrasound showed a medium to high refractivity, and what's interesting that is the CT and MRI show a low density cystic lesions with soft tissue density nodules in the posterior fossa that enhances with the IV contrast. And the diagnosis that was given was a hemangioblastoma of the brainstem. And that probably accounted for her neurological symptoms of nausea and vomiting. And the CT abdomen was basically normal. So she was referred to neurosurgery, and they went ahead to do a posterior fossa craniotomy and C1 and C2 laminectomy for a complete resection of the hemangioma that was involving the medulla. So post-op repeat MRI show a complete removal of the tumor, and her neurological symptoms of headache and nausea, vomiting basically stopped after the surgery. And then she was reassessed by the retinal surface and found that the exudations actually has increased with some hardening of the collections of the exudate at the macula. But because of the locations at the optic nerve, it was considered that it is not a good candidate for laser. So this is the, just a reminder, that was the preoperative, pre-neurosurgery angiogram showing the exudate and the hemangioma. And then the post-surgical picture showing that there is increased extensions of the fluid, and the amount of exudate is certainly a lot more than before the neurosurgery. And you can see that they extended past the previous kind of watermark. So after discussions with the various team members of the management, it was decided to receive the stereostatic directed fractionated radiation to the hemangioma. Well, this is like almost 15 years ago. So back then, there isn't a quick choices to do, and photodynamic therapy is also not a choice because it's right over the nerve. It's so we are quite limited, and so people feel that probably will be a reasonable options to treat. And the vision basically remained the same of 2400. There is this visual field defect that was kind of observed, and over 6 months, the tumor did shrink a bit, and the exudate get a little less, but still persists though. But the vision as well as the visual field remains stable. So we're going to move on to talk about von Hippel-Lindau syndrome, because that is essentially what this young girl has. It was described by Dr. von Hippel back in 1903 as an angiomatosis retinae. Then in 1926, Lindau kind of summarized and described the symptom. That's why the name von Hippel-Lindau syndrome, as they come together. Essentially, it is a rare autosomal disorder with a very high penetrance, and one in about 40,000 live births. And interestingly, the retinal finding, the retinal capillary hemangioma, is probably the most frequent and the earliest manifestations of the von Hippel-Lindau. And a third of the patient has multiple retinal capillary angioma, and half of them were bilateral involved. And the mean age is around 25, so it affected the young patients more commonly. And it was believed that the tumor formations in the von Hippel-Lindau disease follow a two-hit model. So the one allele was constitutionally inactive, so that's the first hit. And then the second allele is become inactivated in the specific tissues, depending on the organ that's involved, in the second hit. And the evidence to support that theory is that for instance, the retinal capillary hemangioma often are not associated with von Hippel-Lindau disease at a later age than those that are associated with VHL. So about younger group, like 25 we mentioned, the older group is 48, which are not associated with VHL. And so the mean age for diagnosis, the VHL diagnosis, the related tumor were significantly younger for those in the sporadic patients. The gene is located on the chromosome 3p 25 to 26, and essentially it affects the kind of blocks the actions of the VHL protein. The VHL protein acts to degrade the hypoxia-induced factor. So the inactivations of the protein will actually cause increased productions of VEGF and causing the tumor to develop. There is also the extraocular features of the VHL, like the hemangioblastoma of the cerebellum, spinal cord, medulla, as our patient has, or pons. And they can also develop retinal carcinoma, pheochromocytoma, different cysts in the body, in the kidney, in the pancreas, in the liver, the ependymode location, ovarian, and pulmonary cysts are also being reported. And you can have pancreatic islet cell tumor and also the lymphatic sac tumor of the inner ear. And the other feature may be that of polycythemia. So if you look at the manifestations and the frequency, you can see that the retinal capillary hemangioma ranges between 57% up to about 70%, depending on the report. And what's interesting is that renal cell carcinoma is the most common cause of death for the patient with von Hippel-Lindau. The risk for developing the solitary retinal capillary hemangioma is mostly clustered at the early ages between 0 and 10 and 10 to 20 that account for almost 70–80% of the patients. So the diagnosis of retinal hemangioma are often done clinically. You can see it using the indirect ophthalmoscope. The fluorescein angiogram can quite nicely illustrate the arterial feeder vessels and the venous drainage vessels, which tend to be tortuous. And what is useful is that it can help to identify the small capillary hemangioma that may not be detected on clinical examinations, as you can see on these pictures of one of my patients. That small capillary hemangioma was hardly detectable on the clinical examinations. And the diagnostic criteria for von Hippel-Lindau disease, if family members affected, then you only need one of the following, like retinal hemangioma or CNS hemangioblastoma, or some of the visual lesion, any of the cysts. But if there's no family member affected, then you need one of the following. You need more than 2 retinal capillary hemangioma, or having CNS hemangioblastoma, or 1 retinal hemangioma with visual lesions, or 1 CNS hemangioblastoma with CNS lesions. So retinal hemangioblastoma is one of the most common features already spoken to, and this tumor can cause problem to the vision by causing exudation, as in our case. And if the exudation is severe, it can cause retinal detachment. And the treatment modalities are mainly that of ablations. So you have using argon, photodynamic therapy, brachytherapy. Like people tried transpupillary thermal therapy, cryo, external beam radiations, and proton beam radiotherapy, as our patient did the external beam radiations. And paraspinal vitrectomy has been done, and mainly if there is retinal detachment, and essentially to repair the complications. And I want to highlight that I think you have great experience here. I think Dr. DB has already kind of published his kind of experience on a very unique technique to ligate the feeder vessels to the hemangioma. I have to say, though, that's not an easy procedure to take with high rate of complications, of course. Laser ablation can be done for the tumor that is small. In fact, it's probably a good idea to do them and not, instead of watching them, because we have seen those hemangioma do grow with time, and they become exudative. So when they are small, it's probably the best time to treat them. So I think in the old days, some people just watch them, but I think that's probably no longer being the suggestions. For the larger tumor, you can do transscleral cryo. As you can see here, it is just 1 day after with still the cryo reactions, and months later you can see the scarring of the hemangioblastoma. People have done surgical excision, as I have alluded to, and I think in here Dr. DB had done ligations of the feeder vessels, and they do work, but they also carry with a significant complications. I'm going to show you one of my case that has bilateral multiple retinal capillary hemangioma, and in the left eye, the scarring is mostly in the periphery, and that's on presentations. And in the right eye, also have multiple peripheral retinal hemangioblastoma, and with like proliferative changes. And you know, interesting, because if you look at the pathophysiology, because there's upregulations of the VEGF, and that's why they tend to get a lot of proliferative changes, as if you are seeing in the diabetics or in PVR cases. And over time, the traction actually get a lot worse, and in fact, you can see there's a band right across the macula. So the decision was to go ahead with surgery, and I mean, you can see all those bands, and some of the bands actually has vessel from the like attached to the tumor. So in this case, they were colorized, and then those membrane were segmented. And once the membrane segmented, we tried to do some of the laser ahead of the time, but because some of the area was not is elevated and the uptake was limited, so we end up needing to do additional laser during the surgery. You can see there's another hemangioma, retinal hemangioma on the side, and you can see those focal area of tractions. Right there, there's one. So, and the idea is just to relieve all that traction that is there, and then laser the capillary hemangioma that's there. I'm going to move it along. So some of them needed to be trimmed with the color because it's so close to the retinal surface. And let me find. Good. So once everything settled, once everything settled down, and so here, that's in the far periphery with very taut tractional band. And so instead of trying to remove it, I just decided to segment it so that they're no longer pulling on the retina surface, because I try to avoid changing this to a rhegmatogenous detachment by just segment the band. And so at the end, it's lasering the angioma, and then I didn't use oil, I just used gas on these patients. So she did well, the traction's relief, but you can see there's some residual scarring that was not able to be completely removed, and the rest of the hemangioma in both eyes was treated with laser. And she remained stable. And the surgical management is not easy, and they tend to be challenging, and I just use one of the reference there, and I think, as I already mentioned, you have good experiences here to manage them. But they do cause kind of limitations for that. But at the same time, though, there are lesions that are not really treatable with surgery or with ablative therapy, mainly those lesions that are located around the optic nerve, or if they are located at the macula. And so in those cases, you need to think of the other type of treatment alternative. So by understanding the pathophysiology, then you can think of the treatment options outside the box. So here is the pathophysiology of the kind of von Hipple Lindau. So in von Hipple Lindau disease, you have this hypoxia-induced factor 2A that's overexpressed because the von Hipple Lindau protein is blocked. So this hypoxia-induced factor 2A is important factor for the degradations of the like VEGF products, and is mediated by the von Hipple Lindau protein. And this protein will regulate the cellular response in whether it's in hypoxia or in normal oxia. So in the von Hipple Lindau diseases, this protein no longer functions, so you have this upregulations or like overexpression, I would say, of the product, and that can cause tumor angiogenesis and apoptosis. And that's how some of the pancreatic neuroepidermal tumors, hemangioma, and different neuroplasm developed. So since I'll go back one more time. Since this is the hypoxia-induced factor 2, or HIFA-2A, is an important factors in the productions of the tumor or the development of the tumor. So people have developed a kind of a drug, which is a first-in-class small molecular inhibitor for the HF2 alpha called belzutifan, which was, I think, from the study looking at the retinal cell carcinoma, is the pivotal trial that actually get the approval in the US and Canada, as well as Great Britain, for this approval as oral medications for the treatments of the renal cell carcinoma. With that, they also observed during the treatment, some of the patients who received the medications actually get reductions of their retinal capillary hemangioma. And then since that time, there was multiple publications showing that the tumor, the retinal hemangioma, reduced when they were putting on when they were receiving the medication. You can see that the larger tumor gets a lot smaller. And so in, I think, 2020, there's a publication looking into the efficacy of oral hypoxia-induced factor 2A inhibitor belzutifan in treatment of patients with von Hipple Lindau disease associated with retinal hemangioblastoma. And they found that all 16 patients who was receiving treatment has a 100% response. And all of the 10 hemangioblastoma has a mean reductions of their hemangioma of 15% or more by month 12. And then about 30%, like this seems to be progressive reductions by month 24 by 2 years. So it was quite promising. And here are some of the patients that they shown seeing the capillary hemangioma at the optic nerve shrink down to more than 30% on these cases. And you can see the various examples that they show, especially those in the kind of vital part of the eye that did very well. And smaller lesion, some almost looks completely disappear. And so the graph basically showing all the cases that the lesion size have reduced with the treatment. And what's interesting is that when they stopped the treatment, the angioma grew back in size. So it's a direct response to the treatment of belzutifan, the H1 alpha 2 inhibitors. And so the conclusion that was provided from the paper suggests that it is a good option to consider for treating retinal hemangioblastoma, and the effect was able to be sustained while the patients were undergoing treatment. It's important, though, that any treatment you need to know the side effects, and most of the patients, in fact, 90% of the patients can develop anemia, although the anemia probably can treatable and reversible with the reductions of the medications. And 2/3 of the patients experienced fatigue, and that also lead to about 1/3 of the patients stopping the therapy. In Vancouver, we working with the oncologists, we have a VHL clinic, and so we were able to look at patients comparing those on belzutifan versus those on control. And we presented that in our recent COS meeting in Vancouver. And so we found that we have 16 patients with the belzutifan versus 30 patients with control. And we've shown that the number of new lesions were significantly lower among those patients receiving the treatment. Here's one of the patients. You can see the hemangioma actually gets smaller after only 6 months of the belzutifan. So in summary, the retinal hemangioma should be treated early, as I said, and the fluorescein angiogram is helpful to identify small lesions, even though you see a large lesion in the examinations. And ablative treatment, whether it will be cryo, laser, is probably the treatment of choice for most of the hemangiomas. And there is kind of challenges and complications related with the surgery. And for those patients that the ablative therapy may not be as easily treated, belzutifan is probably effective in those cases. In addition, I think if you use belzutifan in combination with the ablative surgery, it may make the surgical outcome a little bit more effective. And I thank you for your attention.
Thank you so much. It's a very thorough review and update. I'm sure the audience has a lot of questions. Dr. Sousan, Dr. Devi, Dr. Robio has a lot of experience in vulnerable Lindau, and Dr. Sousan is treating a lot of patients with PDT. So I would like to hear from her just her thoughts and her questions or her update and suggestion.
Good morning, and thank you very much. Very nice, thorough, review of the case. I have not had experience with PDT in hemangioblastoma, but I totally agree with you that checking them regularly and like fishing for these small lesions is the way to go, because I treat them with laser, at the time where I'm able to. I tend to not treat like you have done around the lesion. I tend to ablate the tumor itself. If the tumor is big enough and I find that it's safe to treat the feeding artery, then I treat the feeding artery as well. I always tell the residents and the fellows, be careful because you may have two engorged vessels. Don't treat the vein because you don't want this thing to
rupture,
rupture or just balloon. You want to make sure that there's limited flow going in, but easy access to outflow. I do not have experience with the PDT in those, and I have never tried it in these, but I know of the surgeries, some of the surgeries that were performed here. I have a question for you with the oral medication. Did you try it therefore in the optic nerve head tumors? And if that is the case, was the shrinkage of the tumor accompanied by also shrinkage of the exudation? Because I think that is the main problem, the exudation and the subretinal fluid.
Right, and thank you. I think those are very nice comments. And the patients that I share was seen like 15 years ago. We didn't actually understand pathophysiology that well, and we didn't have the kind of options of treating her with belzutifan, and so that's why she has the radiotherapy treatment. And for those patients that have been reported, yes, the exudative changes do reduce in the peripapillary locations or over the nerve, and together with the shrinkage of the tumor, and mainly because the VEGF productions or the overexpression has been kind of suppressed with the H1 alpha 2 inhibitors, right? So the HIF2 alpha inhibitors. So.
Have you used anti-VEGF injections alone in any of these?
We have used it to control the exudative changes, and I think it is quite helpful when that happens. But the problem is that with the hemangioma, you will keep producing, right? So you will forever be injecting. The VEGF, anti-VEGF does not have any effect to shrink the tumor. It will limit the amount of productions of the fluid by reducing the vascular permeability factor, reducing the VEGF. But it's like you're opening the tap. You try to keep sucking the water while the tap's still running. It is okay that you manage that, but in the long run, you need to close that tap. Right. Yeah.